Okay, thank you very much. So the slide that's up here has got our logo on, which is the Long COVID Support Group, which is basically a support group for people with long COVID. At the moment, there are at least 45,000 people, many from the UK, but all around the world. And this grew really out of the need to support each other. So that's the logo. So I'm going to think about support in the workplace for teachers and teaching staff today. I think Paulina and I, we've sort of come together in a small group. There's about 7 of us in this group called the Long COVID Support Employment Group. And we are part of the Long COVID Support Patient Support Group, as I say. And basically, trying to summarise what we do, I think we're keeping our ear to the ground and our eye on the ball about anything to do with long COVID and the problems people are facing. In particular, issues at work, the impact potentially on benefits, applying for benefits. And really, we're trying to encourage and support any sort of community's action on trying to get what we need as patients. So a lot of advocacy. We are experts by having long COVID, and we really have lived with this since early 2020. And we bring our professional backgrounds, which are relevant. I'm not going to read through all of this, but my story of how I got involved with long COVID was one thing led to another. It's been so strange. I'm actually retired on health grounds pre-COVID, and I'm clinically extremely vulnerable, so I was a shielder. But one thing led to another, as I say, and I joined up with other groups of people with long COVID. And at the moment, I'm helping to develop return to work guidance for the WHO, and I've been involved with the leaflets that I'll tell you about later from our Society of Occupational Medicine. So I think briefly today, this is what I'd like to cover, or we would cover together. What is long COVID? And I'd like you to understand perhaps that it is an infection of the blood vessels, and therefore that's why it affects any part of the body. Try to give you some guidance on what support or self-care and other treatments are out there. Focus on how we return to work after absence. And I hope threaded throughout that some thoughts on how unions can support each other in this. Okay, so what is long COVID? Really, it's the same as in acute COVID. You have the same problems. We've got people with blood clotting, whose oxygen levels are low, particularly on exertion, and who have inflammatory problems all over the body. It's kind of been put across as if this is primarily a respiratory illness, but it isn't. You need to understand that it's an inflammation and infection of the tiniest blood vessels. And therefore, we see symptoms and damage in all parts of the body. The virus has a particular affinity for nerves, and this can be even really tiny nerves. So again, we have them all over the body, so the symptoms may be reflected in that. This is a kind of visual thing, really, to try and say what the commonest problems are. You can get cardiac problems, you can get respiratory problems. Very, very commonly, people with COVID and long COVID have autonomic nervous system dysfunction. And by that, I mean the part of the nervous system that controls our automatic processes, in particular, things like heart rate, breathing, blood pressure, digestion. So this is common. And I've talked about the affinity for nerves, so we get neurological problems. You will have heard about brain fog, or possibly some of you experienced it. And so we get this sort of cognitive effect, which can be really quite disabling in daily life. So those are the commonest things, but there's a whole range of other. I'm not expecting you to read all the small print on this picture. It's an illustration or an infographic that I did for the Society of Occupational Medicine. And you'll see that it says, what's post-COVID condition? I only put that title there because officially that's what some bodies like us to call long COVID, but we very much as patients and people with long COVID, want to stick with the name long COVID because we don't think it's posed anything. This is stuff that never settled and is related. So I think I've put that there because we will see definitions, and some of the official definitions define long COVID or post-COVID condition as something where we've ruled out any sort of physical underlying problem. But actually, as I've said before, it's all part of COVID and all triggered by COVID. So I think the main thing to take from that picture is just the fact that from top to toe, you can be affected by this condition. But it also affects parts of the body that you can't really see, such as hormones and immune problems, new allergies. I put here an illustration actually from Paulina, which I think better describes how it can feel. Common symptoms are, the commonest perhaps are breathlessness, chest pain, and the chest pain commonly described as like an elephant sitting on your chest. This has been one of the weirdest things about COVID, and I'm sure Paulina will agree, that people use the same descriptions for their symptoms. So people will spontaneously describe it's like an elephant sitting on my chest. The snake around the chest in the April part of that picture is for the very tight feeling, almost akin to a squeezing pain you can get around the chest, and that sometimes people call the COVID squeeze. And then I think a lot of us have had this sensation of where on earth has my brain gone? I can't remember things at the moment, I can't concentrate. And literally we say, where's my brain gone? So I have listed there a whole load of other symptoms which are quite common. But as I say, there are just some. Some studies have shown that in people with long COVID, there is organ damage. It typically gets better. So typically, though there may be some passing heart inflammation, typically the specialists are saying that it will get better. But what we see from this study of non-hospitalized people is that, I'm sorry, I've got the figures the wrong way around on that slide. What it should say is that 67% have one organ where there's some evidence of inflammation or damage. 1/3 of this group of people had more than one organ affected. What I want to say to everybody is long COVID is not mild. It's not in the head. It's not just chronic fatigue. I think it's not at all mysterious. If we look at what we know about what COVID does in the acute phase, none of what we're seeing is a mystery. And many specialists will tell us that what we're seeing with COVID has been seen in many other viruses. And just to say that a positive test is not required for diagnosis for many reasons, not least that a negative test may be a false negative. So even with the PCR tests, a substantial proportion will test negative, and we can use a clinical diagnosis, just as we would diagnose measles or chickenpox. We know how to recognize them as doctors. So here are some phrases that, as people experiencing the condition, we've said, bizarre collection of symptoms, but remarkably similar between people, between large numbers of people. And therefore that suggests to me that this is not in everybody's head. And we all know about the relapses that can happen. We'll say more about that in the context of return to work. It's difficult really to know exactly who gets long COVID because it isn't properly studied. Some studies suggest more women than men, but in several populations, it's felt that it's nearer equal. I think men and women just present in different ways. High-risk jobs, people who seem to get it most in terms of workplace. Surveys have shown it's frontline settings such as the NHS and schools. And as I say, I do feel that teaching as a profession has been sadly neglected in terms of the numbers and the extent of people who are having problems with that. So we will do what we can to support you. Let me just give you a little example of a case. This is somebody who in the acute phase was very, very unwell, but not admitted to hospital. She was so confused, she didn't even know how ill she was, and therefore she didn't know that coughing up masses of orange phlegm was something that really should take her to hospital. It was extreme. So she continued with dizziness, palpitations, some very severe facial pain and severe headache on one side. Now, those should have alerted doctors, but it was very difficult to get into anywhere. At 3 months, everything took a turn for the worse, and she was diagnosed with migraine and anxiety. Now, it is common to develop new migraine after COVID, the National Neurological Hospital will tell us, but nothing else was offered. And she became more and more ill, and at 7 months after the acute event, had a brain scan, and it was found that she had a large blood clot in a vein in her head. So we dismiss people at their peril with long COVID. This slide illustrates my observations only, but I think it is coming out in some of the studies. Living through this, I think people either have a very mild illness that gets better after 48 hours, and that's it, they fight it off. And then there's a large proportion who may carry on, and typically you will have heard about the 10-day thing where things can get worse. I then have found that people carry on like that for about 3 months, and then they either get better completely or they have ongoing problems, and we find ourselves at this 18-month stage. So something immune may happen around the 3 months' time. The point of putting it down is that I think if we can get people properly looked after in that first phase, those first few weeks, we might avoid some of this prolonged problem. Many people, to summarize this slide, went to A&E during all this and were told that their high heart rate meant that they were extremely anxious. But high heart rate of 150, 170, up to 250, as some people with long COVID have experienced. Never normal, never normal. And it needs proper investigation. Long COVID clinics have been difficult to access, they promised, and Paulina may say more about that, because we've done surveys. And I'm aware that the situation in Northern Ireland is that they really aren't up and running yet, although I think maybe starting. But early intervention of symptoms and adequate rest in the first place may well cut things down in terms of duration. Again, a wonderful picture here from Pauline. This is what she drew after some of our discussions where we were just so fed up of being told to think positively or have you tried yoga, when actually this needs proper medical intervention. So what can you and we do for ourselves if we become ill after COVID? I think it's proper self-care in the early stages, really key to rest properly. Everyone who's had long COVID says the one thing they would say differently to people starting with it is rest in the early stages. Now, unlike other viruses, this needs to potentially be around about 4 to 6 weeks of real rest. So people need sickness absence, followed by something called activity pacing, which is a sort of method that particularly occupational therapists are very excellent in guiding people about, so pacing very, very gradually. I strongly believe that symptoms need treating earlier on. And I've listed here some of the things that can be done. Do not listen to anyone that says there's no treatment. There's all sorts of things to treat the cardiac complications listed here. There are many, many measures that you can use to treat the autonomic nervous system dysfunction. And they start with lots of non-drug measures. followed by some medication, if necessary, to reduce the heart rate or increase the blood pressure. Due to my pre-COVID problems, I already had autonomic dysfunction quite significantly. And after doing all the sort of self-care measures, adequate hydration and so on, I was put on a drug to raise my blood pressure because my blood pressure is otherwise so low. And that very, very simple drug was life-changing. So whilst I wouldn't say take a drug for everything, there are some times when it can make a real difference for a period of time. You can treat the neuropathic pain, so pain caused by nerve inflammation, very effectively. Get that in early. And actually, the specialists who are seeing a lot of people with COVID say sleep is really important, but can be disturbed because of this autonomic dysfunction, and melatonin can really help. Simple things, get them in early, that would prevent the prolongation of things. So I'm saying all these things because I want you to be aware of colleagues in the workplace who might have these things and what they need to be supported in doing. I've put here an excellent source of advice on the things that you can do or take to help the blood pressure and heart rate. Let me just mention a case here. I think it's very relevant to teaching. Hoarse voice is a common and underreported symptom, and a really hoarse voice or a giving way sort of voice. It's hard to describe. Some people describe the COVID strangle because it's somewhere between a sore throat and a dry throat. So, teacher who had been off work for 10 months with various problems. The voice issues settled by that stage, so they went back to work. On returning, though, within a few hours, developed actual pain around the voice box, and the voice literally just gave way. What should be the next step? I'm not going to ask you to guess, but actually this is where there can be things done to manage it. It's something that would impact so significantly on your work that you should have a specialist assessment. And by that, I mean ear, nose and throat doctor or speech and language therapist. Why? Because it's common to develop swelling and i.e. edema of the larynx or the voice box, even seen at a year down the line. And COVID can affect the nerves to swallowing and speech. So it needs that specialist input. Anything that's having an impact on your ability to work needs other urgent looking at. So these are some of the things that we know work in terms of therapies. I'm just going to check my timing, if that's all right. I'm aware of very much aware of that. And I'm going to hand over to Polina shortly. Things that can help. See an occupational therapist early on. They are one of the professionals that patients have said has helped them the most. We're busy professionals. We're used to being on the go, multitasking and so on. The OTs are really brilliant at helping us overcome the awful fatigue and the difficulty with the physical problems. Okay, those are just some things to be careful of if you have those conditions due to COVID. Just don't be doing anything which raises your heart rate above about 100 and which basically makes you feel worse. At this point, I'm going to hand over to Polina. Let her carry on. Shall I de-share my slides and then you'll share them? Is that your own? Yeah.
Okay, I'll do that. So I'm just going to share my slides. So can you see me and hear me all right? That's okay. So I'm going to talk a bit about return to work, which is the second half. Sorry, can you hear me now?
Yes, Polina, thank you.
Can you hear me now? All right.
Yep.
Okay, so I'm going to talk about return to work, which is the second half of our presentation. So there are some impacts that you can expect on work, and obviously there are different areas on which they impact. So for example, you can have cognitive dysfunction, which obviously makes it difficult to plan, sometimes to remember things. And that is something that does need specialist rehabilitation. It does get better. So if you find you have lost your memory, we always think the brain cannot repair itself. No, it can. It just takes time. It takes rest. It takes spacing. It takes some cognitive exercises as well. When I was ill, I was kind of obsessively doing Sudoku puzzles to build back my numerical memory and pattern matching. And so it does take time. It does a bit of work, but it does come back. There is pain, which might make it problematic for you to talk or stand up, because often it is chest pain. It makes it made worse by talking at length. Obviously fast heart rate, fatigue, which is not just a little bit tired, it's quite debilitating. You literally crash and can't do anything. There is, of course, distress, and it is emotional distress. We hear a lot that, oh, it's all anxiety. No, but COVID, of course, does cause anxiety, and it does cause depression, especially if the medical professionals have ignored you and you've struggled to access help. That causes psychological problems of its own, as does, inability to carry on with your normal activities and your normal work, becoming socially isolated and so on. It is a relapsing condition. So you will find that people, and it could be colleagues, it could be friends, it could be bosses, will say, oh, I'm glad to hear you're better. And at that time, yes, you might be better. I'm glad you're recovering. But recovery in long COVID is not linear. So you will have good weeks and bad weeks. Overall, you will be improving over time, but there will be times when your condition deteriorates or new symptoms kick in, and people should be aware of that on phased returns, because from our surveys we've heard of a lot of kind of what we call failed phased returns, when people have come back to work over a period of weeks, and then at the end of or halfway through those weeks or at the end of that time, they crash and have another relapse. What you can expect, as Claire mentioned, autonomic dysfunction, which is made worse, by prolonged standing or sitting if you're immobile for a long time, or there is a lot of pressure on certain areas of your body that could exacerbate that. Fatigue, so again, prolonged work without a break exacerbates that. Neurocognitive problems such as difficulties with concentrations can have implication on safety, procedures, what happens in an emergency when you're looking after a class, for example. You need to think and act quickly, and that could be an issue. And you would have reduced stamina for strenuous exertion. So I've heard of teachers, for example, who have come back to work with long COVID, being asked, let's say, to take a group of children hill hiking. Now that's not something they might be able to do, and perhaps another member of staff should be drafted in that situation, because they will have heart problems, they will have breathing issues, and they just will not have the physical endurance necessarily to do those kind of activities. So what do we recommend? In our surveys, and the Trade Union Congress has conducted surveys into the impact of long COVID on work. About just over half of people have returned to work successfully, just under half typically have not. And it could have been that they have had to stay off on long-term sick leave. It could be that they have tried to return and as I managed to have relapsed and had their symptoms exacerbated and had to either go on leave, or some have lost their jobs, and I will talk about it later. And what makes a difference in whether people can stay in work or not, we have found a major point is whether adjustments are made to them in work to accommodate them. People with long-term illnesses, and although long COVID is not yet classed as a disability, it is, for all sense and purposes, a disability. We know that most people have it for longer than 12 months. It fits every category of what a disability is, but it is a disabling condition. People with disability should not be expected to adapt and adjust to their workplace. Really, the workplace should adjust to them. Because there are so many symptoms, and this is multi-system disease, and there are so many different symptoms and different organs affected, there is no one-fit-all solution. So it has to be an individualized assessment, and this should be carried out by doctors, by occupational health professionals. And those adjustments should be tailored to the individual, to their specific health problems. We have found that when people have returned to work successfully, another major factor has been referral to occupational health. Now, normally it is your employer, your boss, who will refer you, but you have to ask them if they don't volunteer. And you can also self-refer if you have a disability passport. If you don't, there are other symptoms, but you can self-refer to occupational health. And even if your doctor has not been particularly supportive, and some doctors still unfortunately aren't, occupational health can make those recommendations to your employer for those adjustments. They can assess what your health needs are, what your problems are, and make suggestions as to how to adjust your work to them. It could be the hours that you work. It could be that you need more frequent breaks. It might be that you need adjusted duties for a period of time or for a longer period. It might be that you have to adjust your workspace. People have had problems with vision. They have had problems with manual dexterity. Some have had problems with standing, so perhaps they will need to sit more. They might need adaptation with their computer, with their keyboard, their mouse, and so forth. So lighting, ventilation. Ventilation is actually quite a key issue because we have to talk about health and safety. From TUC and our own surveys, more than 2/3 of people who have caught COVID and developed long COVID are in frontline professions. They are largely doctors, nurses, teachers, care workers, childcare workers, people who are in frontline jobs, and teachers are very, very prominent among them. So when they return to work, there does need to be that consideration of safety. The best way to prevent long COVID is not to catch COVID in the first place. So masking, ventilation, distancing, hygiene are very important. When we talk about extended phased returns, we're talking about minimum 4 weeks. But again, that needs to be constantly reviewed and reconsidered because people can relapse during it. Dr. Kim Burton, who has done a lot of work in vocational rehabilitation, says that success of phased return depends on regular review and readjustment with line manager. So people should not just assume, bosses should not just assume automatically that people will be able to return to their normal level of work within 4 weeks. That's unfortunately is not how this condition works. Where it has been difficult, as Claire mentioned, long COVID clinics, even in England where they exist, are not accessible to everyone. They have long waiting lists. People even wait a long time for referral. It could be half a year before you get referred, and it could be another 3 months plus before you get seen. So I know schools are not very likely to do it, but it is something that can make a difference where an employer can fund scans or appointments if there are delays in NHS. The Society of Occupational Medicine, with a lot of help from Claire, has produced guides on return to work, both for employees and for employers. And we would really advise you to look at those resources on the SOM website. They have a whole section dedicated to COVID, and those resources can be found there. And this is something you can just print out and show your manager. If they don't understand the condition, how to deal with you, that's a very helpful guide. So some examples of adjustments, as I've mentioned, could be altered tasks. There needs to be clear objectives and review along the way, so you know how long those adjustments need to last, whether they're going to be permanent, whether they're going to be over a set period of weeks. After a period of time, every so many weeks, they have to be reviewed. How can you support colleagues? Give them time for appointments, provide cover, have body support, perhaps work share, and where possible have alterations so that people can take more regular breaks, have more regular shift patterns, lighten their workload where possible. So this is Dr. Burton's action plan, and every employee should have one. It should include focus on how the person working perceives their abilities, what they think they can do and what they can't do. And of course, if you are that worker, you have to be honest with your manager. Hiding your symptoms because you're afraid of losing your job is not actually going to help you, because if you try to push through those symptoms, you are not going to get better faster. More likely, it will prolong your condition. You have to identify obstacles in your way, and it could include health and safety concerns, such as ventilations, for example. So these are all examples of adjustments which I've mentioned. I'm aware of our time, so I will press on. Again, in the case of autonomic dysfunction, things you can do for yourself is drink extra fluids. If you're finding it hard to eat big meals, have small regular ones, have windows open so you don't get overheat, and generally have temperature regulation. And pace yourself. Try to reduce the number of times you have to walk from one place to another. Reduce your tasks, because you're only going to have limited amount of energy, and dedicate it to what is most important. What issues we're finding now? We conducted a survey at the end of September, which was for the purpose of responding to the Department of Work and Pensions green paper on disability and work. And in our survey, and that has been consistent also with other surveys, 98% of people were of working age. There had been this perception that COVID mostly affects older people, but most of the people are between the ages 80 and 64. They're during their active working lives, and the biggest group, 43% in our survey, was aged 45 to 54, and the second largest group was in their 30s and early 40s. So these are the people in the prime of their careers and experience. And we're hearing from teachers who've been working in their profession for 10, 15, 20 years, now losing their jobs, permanently leaving the profession because of long COVID. And that is really heartbreaking. And of course, it is a loss to them. It is very much a loss of their identity, because your self-perception, your self-esteem, how you view yourself in the world is often very much tied in with your career and your profession. And it is also a loss to education and to the children who will not have those dedicated teachers that have dedicated so many years of their life to that profession. So that's a very bad situation for everyone. And the impact on the individual, of course, is the job loss, loss of financial independence, struggle to attain benefits, which is often a struggle of its own that takes a year, often in many cases. The negative labels that this is somehow psychological illness, all in the mind. Women suffer particularly from misogyny, where they're told they're hysterical or they're imagining things, and that is very common, and that can really destroy your self-esteem. You start doubting your own sanity. But long COVID is not in your mind. It is a physiological disease. It is just not adequately addressed at this point. But for the employer, there are also very negative impacts, because more and more staff is being lost. When the TEC conducted their survey, it was about 1 in 20 people who had lost their job as a result of COVID, whether by dismissal, resignation, or being singled out for redundancy. By the time we conducted our own survey in September, it was about 1 in 13 people, and the frequency we're hearing of it now is it's coming close to 1 in 10. So they're losing experience and skills. There's a lot of media disinformation, again, where it's discussed as psychological illness and you have completely uninformed people commenting on it. So that just perpetuates the problem if employers listen to that. So I've put slides here on how human resources can manage long-term sickness, but I've already mentioned it's a flexible approach. Some work is better than none. So even if people can do a limited amount of work, it's better than being out of work for a prolonged period of time. So to keep on top of your skills and the requirements that you have at work. So you have maintained your social world as well. It's very important. And yes, colleagues need to be educated and realize that this is not a linear recovery, and you're not just suddenly going to magically get better over a 4-week period of time. Although long COVID is not classed as a disability. In England, this is a Equality Act 2010. In Northern Ireland, it's Disability Discrimination Act 1995 that defined disability as physical or mental impairment, which has a substantial and long-term adverse effect on the person's ability to carry out normal day-to-day activities. Now, long-term, we have already determined that it can be a long-term illness. From our survey, about 40% of people, I think it was, had long COVID for more than 12 months, and about a quarter had it for 18 months or more. So it is a long-term illness under those disability acts. And as Claire has explained, it does have a very substantial adverse impact on the ability to carry out normal tasks. So what can unions do? When people are negotiating for adjustments, when they're explaining their situation to the manager, they should not be left to do that on their own. That's what union reps are there for. So if you are a union rep, if you can accompany your member into the meeting, please do so. If you suddenly find that the manager says, oh, we'll have this meeting tomorrow morning at 9, and there is no time to engage your rep, try to reschedule that meeting so they don't go in on their own. Very often people have found themselves in situations where it's them, the manager, somebody from HR, a department head, so there may be 2 or 3 people in front of them, and one of them, if they have cognitive problems, if they have difficulties with breathing or speaking, they're going to find it even harder to put their point across and to argue their case. That's where the union rep can become their voice. Also, people are now facing disciplinary procedures, having to bring up grievances, sometimes go to the tribunal. And although unions have their lawyers, funded through members' fees, union lawyers are often waiting for a successful test case before they take one on, and they expect a very high burden of proof. Unfortunately, we can't wait for a test case because the chicken and egg situations, and we're finding that tribunals, especially in grievances, are deliberately being kicked into the long grass. Managers are not responding, HR are not responding, their lawyers are not responding, and deliberately drawing out that process so that test case does not happen. It will not happen until it happens. So the unions do need to make their lawyers accessible to their members. So if employees with long COVID are not managed, obviously it's an impact on everyone. There are staffing issues, there is stress and negative consequences for the individuals. Employers who lose their personnel through long COVID are going to suffer reputational damage because it's an effect of their bad management, and they're going to lose skills and they're going to lose experience. Again, schools are safety critical places. If you don't allow people to manage their cognitive issues, that's going to become a risk. So we're coming to the end of that slide, and I'm going to say that the best thing you can do really is provide people with support, because people with long COVID have very little support from the medical profession. It is lucky when they do, but when they come across employment problems, that's where their unions can support them. And thank you very much.
Thank you, Paulina. We have one question in the question box at the minute. It has come in from Dennis, and the question is, does the slide on the work adjustments after COVID refer only to returning to work after long COVID, or are there adjustments for staff who return to work after short-term absence due to COVID?
Yeah, that applies also to absence due to COVID.
Okay. Thank you.
They are generic. Well, they're standard. They've been around, so they could apply to any sickness absence situation. They would all be good practice and should be followed.
Lovely, thank you. And we have a question from Richard. How do you suggest we improve ventilation in the classroom when the room is already cold and uncomfortable?
This is really difficult, and Paulina can answer as well. But as Paulina said, the best thing is not to get COVID in the first place. So we really recommend prevention. The ways that we have to mitigate our hazards like this are either via what I would loosely term as engineering, but that could mean anything that involves the structure of the building. Then you've got ventilation issues, which is actually a very complex specialist area. So I'm not qualified to say that. And then you've got masking and so on. So, and if I think we need to bring back mask mandates, or people should practice that anyway. And that's going to sound contentious, but actually it really works if everybody's wearing masks, and we're potentially facing another threat. I'm not a specialist in ventilation, but what you need is air movement within a room, and that can be achieved in many, many different ways. There are carbon dioxide monitors, which can give an indication. My understanding was that all schools were supposed to have them, but it hasn't happened. And they would tell you when the room air needs changing, which would give a better guide as when to open windows or other ventilation measures. It's a really difficult one, but it's absolute priority. And it may be that it's a question of having those monitors and then changing the air when that's indicated. Paulina, do you have anything to add?
We can probably share some resources on ventilation, but yes, essentially they rely on carbon monoxide detectors. And there isn't really a good solution if you don't have inbuilt ventilation other than opening windows and letting the air flow through. And it's not just a case of a window, air has to go somewhere. So the most important thing is that it circulates, that there isn't stale air in the building. There are also small scrubbers available that, again, you can put air through, so it is purified. So there are a number of solutions. It does depend on what is available in the building, whether there is an inbuilt ventilation system, but I know lots of schools there aren't. Yeah. So the best thing you can do in that situation is keep windows open, not necessarily wide open, but if you have more than one window, then if you have them slightly open, then that means the air circulates around the classroom from one window and the other going in and out. And masks are important. I know we've been told in September it's all over and we don't need masks and we don't need to distance and we don't need to sanitize our hands. But that is clearly not the case, especially as new and vaccine-resistant strains are emerging. So yes, masks need to be in place for that reason. I very much expect that very shortly we'll go back into those measures. Just out of necessity.
Yeah, lovely, thank you. And Richard, just our next session is on ventilation, so we might get more information as well in the next session, so that's great.
Brilliant.
Any other questions? No, there's nothing coming through at the moment. Well, that's brilliant. Well, that just Oh, that's a message from Dalma to say thank you. It was brilliant. That just leaves me to say thank you so much, Claire and Paulina, for your time this morning to come and speak to us. It's been very interesting. I know I've made lots of notes to go back to school to pass on to some colleagues. So thank you very much for this morning.